Antenatal thromboprophylaxis. The Embrace Report 2016 shows that the commonest direct cause of maternal death, and the fifth commonest cause overall, is thrombus and thromboembolism. Green Dot Guideline 37A is casting an increasingly wide net for recommending dalteparin from 28 weeks or earlier. A combination of just a few common risk factors is enough to warrant this. If all our ladies were fit and healthy, this wouldn't be such a problem. However, many of our ladies have significant risk factors for venous thromboembolism. In the current system, the GP is involved in getting the lady the dalteparin that she needs. When she sees a midwife at her booking appointment, the midwife does a risk assessment. If the patient needs injections, this letter is generated. The patient takes to the GP, who converts it to a prescription, which the patient takes to the pharmacy to be dispensed. The letter asks the GP to arrange training if necessary, but following my discussions with patients, I found that to be a little variable. Sometimes the pharmacy can help with instructions for administration, but that too I found to be unreliable. In reality, at this stage, often the patients are left until their next appointment with the community midwife. Going forward, the GP have raised concerns. Quoting guidelines from the General Medical Council, they say they no longer want to be involved in prescribing dalteparin. They receive the instruction about a patient they may never have seen and may never see, and they don't feel comfortable prescribing under those circumstances. So going forward, this isn't going to be an option. We need to devise a system to get the dalteparin to the patients that need it in a way that's reliable, safe and inexpensive. There will inevitably be resource implication, but if we streamline the process, we can keep this to a minimum. Following discussion with the CCG, I'm optimistic they'll help us find a way to do this which is ideally cost neutral, at least with regard to drug doses. Now, the system we devise should avoid women having to travel across Kent with pieces of paper to get the medication they need, especially when a trip for some women can involve several hours on public transport or expensive taxi fares. We've looked at each step in this process, and for each step we've considered the most reliable, safe and inexpensive way of getting it done. Following discussion with pharmacy, with community midwives, with obstetricians, we've determined that the most feasible way of doing this will be like this. There's specific reasons why some of those other options are not feasible, which I'll be happy to explain later. So, the patient would see the community midwife at 12 weeks who would do a VT risk assessment. The patient would receive written information leaflets, and the midwife would take the letter of referral and email it to obstetrics. They'll look in the hospital notes if necessary, call the patient to clarify any details if required. That would be converted to a prescription which will go in the post to the patient. That can be taken to her local pharmacy to be dispensed. Then, depending on her needs, she'll either administer that first injection on her own, or if necessary, the community midwife might be able to help with any instructions as required. How can we implement this in the immediate, short, medium and long term? The GPs are going to immediately stop issuing prescriptions, so in the immediate term we need to duplicate that to make sure that no patients are missed. In the short term, there are efficiencies that can be made. If the letter includes details about the specific risk, contact details, details of past medication, and confirmation that patient information leaflets have been given, then that will speed up the process of issuing prescriptions for the obstetricians. In the medium term, I envisage a database that will keep track of which patients need dalteparin. It could connect to the hospital systems to pull patient information, and it may even be able to print out prescriptions electronically. This will cut down on data entry administration, streamline the prescriptions, and importantly, ensure that repeats are issued in a reliable and timely fashion. In the long term, there are discussions about something that would be called obstetric risk assessment clinic, and this would absorb all the difficulties we're having with dalteparin and also reliably prescribe other medications patients need as well. A whole new streamlined way of delivering antenatal care, which is more convenient for the patient, better for the obstetricians, avoids unnecessary appointments, and is more cost effective. But that's for another day. There will be some resource implications, but we can keep them to the absolute minimum. I'm optimistic that obstetrician time can be absorbed, at least in the short term. That will have to be kept under review. We'll need some admin support to keep track of referrals and make sure nothing is lost. Postage stamps will be the most cost-effective way to get the prescription to the patients, and the CCG has indicated they will help us with the drug cost. That's where we are so far with antenatal VTE prophylaxis. Thank you.